Okay, so for the sake of time, we'll just, Otis, this was really, I'm sure each and every of us learned something. Thank you for your perspective very much. We're going to turn to oncologic imaging, gaps and challenges to high quality cancer diagnosis in clinical practice. Imaging is on everybody's mind. I don't know if you noticed as you walked into the National Academy of Science building, there is a wall of knowledge, and on the wall of knowledge there is imaging. Actually, there are two images, and they are both MRIs. Diagnostic imaging is a critical component in cancer care. In the study published by Dr. Zhao, president of the National Academy of Science, in 2016, he says that diagnostic tests influence an estimated 60 to 70% of all treatments. In cancer care, the role of imaging is even higher because we use imaging for the continuum from screening, diagnosis, staging, treatment, follow-up. So it really affects much higher than 70% of treatment decisions. Because we are a very diverse audience, I apologize to my friends in radiology, but cancer, when we look at every step of cancer care, imaging is established for cancer screening, so far for breast and lung cancer. It is essential in cancer detection localization, and it's really widely used in treatment planning. Not long ago, exploratory laparotomy was the most common procedure in any hospital, and it was used for diagnostics. Today, we no longer use exploratory laparotomy to open up and look what's happening, and very often in cancer care close, we have really replaced that by virtual laparotomy, by imaging. And this is just an example of a patient with ovarian cancer. There is a large ovarian cancer in the pelvis. There is a mental caking, and the supradiaphragmatic node, which is colored in red, indicates to a surgeon that patient is inoperable and requires neoadjuvant chemotherapy followed by surgery later on. So this detail and precision in treatment planning, imaging is making a tremendous progress. And then in treatment follow-up, monitoring treatment response and detection of tumor recurrence, especially for those cancers that don't have biomarkers, imaging is really the primary methodology. So imaging also has a broad scope, and there are many unmet needs. The need for training and expertise in oncologic imaging is not widely acknowledged or recognized. We think that anybody can read oncologic imaging, and I'll show you that perhaps is not correct. 50% of all cases in any imaging practice today, community freestanding imaging center, except for orthopedics and pediatrics, are oncology related. We don't have the exact data. This is a personal survey asking many of my friends to say, and they all agree at least half what they do today is oncology related. And then we already said 65% of cancer patients are treated in a community setting. And that report was done in 2010-11, and I'm sure if we look today that actually the percentage may be even higher. So there is a need for oncologic imaging expertise which extends far beyond university and the cancer centers. And that's a number one recognition acknowledgement we have to have. This is a quote from one of our fellows. We have 17 oncologic imaging fellows every year. They are in a tremendous demand, They go mostly to community hospitals, and emails and thank you notes such as this one is almost routine. Right out of fellowship in their community setting, they are considered oncology experts, and everybody brings them cases. And then one thing that she said, they usually don't realize. You don't know what you're missing. Ignorance is blessed. It's only after you get proper training then people realize how much knowledge is there that they really don't have. Those are the data to show you that they are indeed correct. This is a summary of the literature from a peer review publications. I divided them into simply disagreement when an image is read by an oncologic specialist and management change. When we look at the management change and we look at the numbers that in one study, 2012, for breast, the management was changed, the treatment was changed, 26%, head and neck, 38%, another breast study, 53%, neuro, all brain, all cases included, were 53%. Okay, this is really good. I'm going to stand like this, it's easier. Sorry for that. GYN, that was our own study, 20%, and then breast, depending, 13 or 32, depending on the modality that was used, and the last study published in pancreas, 20%. When we say management change, it means either operable or not operable. That's number one. Second one was benign or malignant. There are cases that are called malignant. They come to Memorial for second review. It's clearly benign. So when you take all of this account, you realize the gaps in knowledge and recognition for the importance of the special expertise in oncologic imaging. It isn't only our data from management and disagreement. Those are data from CRICO, where number one cause for the malpractices is clinical judgment. In the clinical judgment, the top choices that were done were either ordering the wrong exam or having delay, but second one is misinterpretation. And misinterpretation includes radiology, pathology, laboratory data, all the diagnostic tools that we have. This is very worrisome, and this is why I'm so grateful that the forum agreed that we discuss those issues in a large interdisciplinary group like this one and see how to move forward. So where are the oncologic imaging experts? There are very few role models. There are very few role models, either personal or institutional. Very often, oncologic imaging, expertise in imaging, is really not recognized. Second, there is a lack of appreciation for the additional knowledge that we need if we want to be oncologic imaging experts. Expertise in oncology extends far beyond pattern recognition. It includes knowing cancer biology, understanding that cancer is a multi-system disease, treatment options, especially all the new targeted therapy and all the molecular imaging that we are introducing, needs a different level of knowledge. The needs and expectation of referring physician. Oncologic report has to be not only accurate, has to be clinically relevant, and has to be actionable. And then there is a mandate to participate in the interdisciplinary team-based cancer care. How are we going to organize that? I don't know. But imaging, oncologic imaging in isolation just doesn't have the same value as it does in the interdisciplinary team. And then there is a big misconception about the job market, fear that oncologic imager can only work in a tertiary care center. That's absolutely not true, and we know that from our fellows, which are in tremendous demand. Now, radiology as a specialty is moving towards subspecialization. It did take us a long time, but we are getting there. This is a 2017 American College of Radiology Commission on Human Resource Workforce Survey. It started in 2012, and as they compared 2012 to 2017, in 2012, more than 35% of radiologists said they are general radiologists. Today, that's a little more than 10%. So we are moving in the right direction, but we have to really all work towards doing even more. This is an example from a study to show you the difference. It is not about the equipment. It is about the person that interprets those images. This is a study in prostate cancer looking at the incremental value of MRI. Very often we ask question, why MRI? Does it really help? And you need to show that it really helps. This is 181 patients. The study is from Memorial Sloan Kettering. So we ask so-called general MRI radiologists to interpret the MRI, and there was absolutely no incremental value between their interpretation and the clinical assessment. None. As you see, the p-value is 0.3. Look what happens with a GU MRI radiologist. The same set of patients interprets, they offer incremental value. So that's change in management right here in our own study with our own group, except we took liver guys to read MRIs, and they were not as good and as a GU people. So subspecialization in radiology is absolutely essential. How do we increase expertise in oncologic imaging? Starting with Oncologic Imaging Fellowship. There are only 5 Oncologic Imaging Fellowships in the United States. We offer at least 250 imaging fellowships for other specialty. So there is a certain imbalance. Second, when we look, should we have a dedicated oncologic imaging training that's offered to our fourth-year students, our residents, as a mini fellowship? We have a mini fellowship. Should oncology be one of those mini fellowships? And then do we have, when you have a regular GI fellowship or GU fellowship, should there be a dedicated curriculum? There is a well-defined curriculum for oncologic imaging. Should we have oncologic imaging sections within the department? UCLA has it. I'm sure there are more. I only know of those 2. One is UCLA. One is Staten Island. They read abdomen, they read everything else, but they also identify themselves as specialists. So everybody in the department can come for second opinion. We need to develop and expand both oncologic imaging CMEs, there are very few, and peer learning programs that are really designed and changed to gear to oncologic imaging. And then one area which may not be very popular, I actually think it may be very much needed, and that's oncologic imaging certificate of edit qualification. Just like today we have in surgery, we have in medical oncology, they're really subspecialized. We give the diagnosis. We are the starting point. We should have a special expertise in understanding what's going on. And that's even more important as we're going to the age of precision oncology. Imaging is extremely important, but it is only one in that matrix of the complex integrated diagnostics. Today, we are at the age of convergence of life science, physical science, and engineering. Each and every aspect on this complicated graph is essential to the proper diagnostics, there will not be precision oncology or precision medicine without precision diagnostics. And that's where imaging, pathology, genomics are so very essential. So as we look at integrated diagnostics and convergence, imaging and all the domain of measurements are crucial. Unless we solve the first graph, which is graph of domain measurements, you won't have data analytics to do the algorithms and really move without quantitative pathology and quantitative radiology. Bioengineering and computational methods are not going to have entry points to really develop quantitative precision measurements, which are essential for the next generation diagnostics. So there is a lot of work to be done today for everyday work, and there's even more to be done for tomorrow to really have precision oncology. So points for our discussion. Number one, we have to recognize the need for expertise in oncologic imaging. It is not just a side thought, it's a central. Second, we need to increase venues for education in oncologic imaging, going to be fellowship, peer learning, CME courses. We have to institute oncologic imaging certificate of special qualification. And then should we form second opinion networks and cancer imaging consortia? So for those that don't have experts in their own department, have an easy venue to get the second opinion. Those are just points. So oncologic imaging at the intersection of human ingenuity and intelligent technology, I think we also need to, at the same time, already today, and we're already doing, facilitate development of artificial intelligence and machine learning to take over some repetitive tasks. Tumor measurements, getting me pertinent history right away, so I don't have to look through the medical records for 20 minutes to really find out what you are looking for. And then implement data analytics and integrated diagnosis as predictive and prognostic biomarker of cancer care. I think the times have never been better to really move and understand the importance of diagnostics, which is pathology and imaging, in moving a cancer care forward. So call to action, just for all of us to remember, getting the right diagnosis is a key aspect of healthcare, cancer care. The diagnostic process is complex, and it's getting even more complex. And improving diagnosis will require collaboration and widespread commitment to change. And this is why we are all here. And again, thank you very much for your attention, and thank you for coming.
Yeah, question.
Oh, you want questions? I thought it's a discussion. Okay. Sorry. Chris is in charge of the session, and he said if you have any questions now, or would you like to have questions later? Any questions for either Otis or myself? No, we'll discuss it. Thank you, Chris.